Welcome, friends. Welcome to our fifth season of Rack Diabetes Challenge. Diabetes is a rising trend worldwide, and every year the statistics around the world change. As per IDF, in 2024, the prevalence of diabetes in UAE was around 20.7%, which includes pre-diabetic, diabetic, and on medications. Yet there are many which are undiagnosed. Just to promote the awareness for diabetes, RAC Hospital, in association with Ministry of Health, organizes RAC Diabetes Challenge every year. And every year, people from UAE participate in this challenge to achieve a good health as well as well-controlled blood sugar levels. This year, we have around 5,000 participants enrolled in the challenge. As a part of challenge, the lucky and determined participants wins the award. That's true, it's a challenge. And to support the participants in their journey to diabetes management, RAC Hospital connects with all participants to provide weekly health tips and also conducts weekly health talks by experts. Today, we are starting our first session on Diabeat webinar series for RAC Diabetic Challenge 2025 with an interesting and much searched topic, Nuances of Diabetes Care. Means every year there are some new things which are coming for diabetic care. There are new protocols, there are new approach, new medication, many more things are there. So for this, I'm pleased to introduce our esteemed speaker, Dr. Kishore Katal, who is very experienced endocrinologist. He's in our RAC hospital. He earned his degree in medicine from Gandhi Medical College, Hyderabad, and pursued his MD in internal medicine from Osmania University. He then specialized in endocrinology and metabolism from very prestigious SGPGI, Lucknow. Dr. Kishore has a strong academic foundation with over 15 years of extensive experience in clinical endocrinology. He served in several leading medical institutions in India and the UAE. And he recently held the position of an associate professor at AIMS, Nagpur, one of the prestigious institutions. His medical background includes academic, research, and hands-on clinical practice in managing complex endocrine disorders. To mention few, his area of expertise, he's expert in type 1, type 2 diabetes with chronic or comorbid conditions of kidney, liver, and heart disease. His focus is more on diabetes in young people, gestational diabetes, and diabetic education. He treats endocrine diseases of thyroid, parathyroid, pituitary, and adrenal glands. And of course, PCOS and hirsutism management also. And for this, he fluently speaks English, Hindi, Urdu, and Telugu. So without wasting much time, I welcome Dr. Kishore to present his session. Dr. Kishore, all yours.
Thank you, Dr. Vilku. Am I audible?
Yes, Doc. Clear.
Okay. Thank you, Dr. Vilk, for your warm introduction. Today, good morning, everyone. Today, I will talk about this diabetic care nuances in brief, so that we can have a good time for discussion at the end. Can you see the screen?
Not yet, Doc. Yes, Doc. Now we can. You can put it in the slideshow.
Yeah. Is it
Perfect.
okay? Everyone can see the slides?
Perfect.
Okay, I'm Dr. Kishore, working as consultant endocrinologist at RAC Hospital. So I will tell you in brief about this insights on diabetes care nuances. So before going to this, I would like to tell you in few slides about the basics of diabetes. So everybody know about the diagnostic criteria. So we should be knowing when somebody is called diabetic, when somebody is pre-diabetic, and what is the normal range. So if normal blood sugar in the fasting is below 100 is normal, and then after 2 hours of food or after 2 hours of 75 grams of glucose, it is 100 to 140 is normal. Somewhere between 100 to 125 is the orange color. This is the pre-diabetic range. Similarly, after glucose or after food, somewhere it is between 100 to 199 is considered pre-diabetes. In the red, you can see red color more than 125 and then more than 200 after food. This is patients, you can say they are having diabetes. Similarly, another one is the HbA1c. HbA1c less than 5.7 is normal. 5.7 to 6.5 in orange color, this is the pre-diabetic range. And then above 6.4 is considered diabetes. This is in brief about diagnostic criteria that we use for diagnosing diabetes and pre-diabetes. So you know about the symptoms. There will be weight loss, increased tiredness, increased hunger, excessive thirst, urination, and then blurring of vision. There will be non-healing of the wounds. So one more important thing is all patients will not have the symptoms. Patients will come and say, doctor, I don't have any symptoms, but my sugars are high. If there is a gradual increase in the sugar, if the sugar rises very slowly, then you will not have any symptoms. Okay, if there is a sudden increase in the sugar, then you may get symptoms. That's why just not only does depend on the symptoms, then I will tell you in following slides when you will suspect you having diabetes. So the types of diabetes that we know, the type 1 diabetes, where there will be insulin absolute deficiency will be there, and they will have diabetes at very young age. They may need insulin in future. And then type 2 diabetes, they will have normal production of insulin, but the action of the insulin is defect. So that is called insulin resistance. So they may not require insulin. They need other medications, diet and exercise patterns to reduce this insulin resistance so that they will have good glycemic control, good sugar control. The other one that we'll see during pregnancy, if there is a high sugar, that is called gestational diabetes. So these are the main three varieties. Other varieties are many more, but these are very commonly we see. So complications, one thing I want to tell you about the diabetic complications is the eye. So it can involve retina layer causing problem in the retina, in the lens, cataract, or maybe pressure changes. When we ask the patient to meet eye doctor for retina screening in the eye, complication screening of the eye, then they will say, doctor, my eyesight is very good. Right now my sugars are well controlled. Why do you want me to see an ophthalmologist or eye doctor? That is because every year annually they should be screened for retinopathy by ophthalmologist or eye doctor, a specialist. That is because at the early stage you can pick up if there is any change, if there is any problem in the retina, because outer part of the outer layers of the retina there is some spot. You may not have problem in the vision. By the time you come up with a problem in the vision, then there might have been extensive spots, many spots in the retina. Then the doctor may not be doing it, may not do much treatment. So try to do the screening every 1 year with a specialist eye doctor for retinopathy, and then the other cataract and glaucoma changes. That is the pressure changes. Similarly, regarding the brain stroke, then heart disease, these are some of the complications you will see because of the uncontrolled diabetes. Very important thing I would like to stress upon diabetic nephropathy, that is the kidney involvement. So everybody will say my creatinine is normal. Okay, creatinine will be very last to raise, that increase to get a diabetic kidney disease. So before that, very important thing is the protein loss in the urine. So if anybody with diabetes at the time of diagnosis, and then every 1 year, they should be screening for these kidney complications. So creatinine will be very last to raise. So even before that, you can diagnose by sending the urine sample if there is a microprotein, microalbumin in the urine. So if that is there, that is the starting of involvement of the kidneys. Then there are certain medications and change in the lifestyle, and then diabetes control, blood pressure control, and cholesterol control to reverse it. So that is completely reversible. Similarly, a patient, if they notice there is a frothy urine, very difficult to flush the urination, then these are some of the things where you can come to the doctor, because that is one sign of there is a protein loss in the urine. Okay. Other things, there may be a delayed healing of the wound, becoming gangrene, and then clotting, causing the peripheral vascular disease. Okay, these are some of the neuropathy. The nerves can be involved. They will be tingling, burning, and then numbness initially. Later on, if it is neglected, can lead to injuries which you may not be aware. Then it can lead to ulcer formation. Okay, then it will be turn into a gangrene. So the risk factors for diabetes. So always a family history of diabetes, the genetic history, because the type 2 diabetes can run in families, but not type 1 diabetes. Okay. So if there is a family history of diabetes, that is a non-modifiable, that we cannot change it. So other things which we can change the risk factors are overweight or obesity, then inactive lifestyle, if there is high blood pressure, high cholesterol, these two things. So there are very good studies to say somebody who is having high blood pressure or high cholesterol, there is an increased risk of getting diabetes. So those with high blood pressure and high cholesterol, they can also they should go and screen regularly for diabetes. And then one more thing is that those who are having gestational diabetes, that is diabetes during pregnancy, there is a 40% increased chance of getting type 2 diabetes in future. So not only during pregnancy, soon after delivery, in the postpartum period, the 6 weeks after delivery, we ask them to do glucose tolerance test like they might have done during pregnancy with 75 grams of glucose and all. The same thing has to be repeated at the end of 6 weeks. So this everybody should remember that soon after delivery, 6 weeks glucose tolerance should be done, because in that particular point of time you can know if there is any persistence of high sugar that was there during pregnancy that is carried upon after delivery also. So even after that, every 1 year they should check the sugar levels, so that there is no type 2 diabetes. And then age more than 40 years, they should very frequently check their blood sugar levels. But if there is a family history, above 35 years, they should go and check the blood sugar levels every 1 year. So another very important reversible thing is the pre-diabetic range. So if you find fasting sugar is somewhere between 100 to 125, and then after food, if it is between 140 to 199, this is a condition called prediabetes or the borderline sugars. So this is the point where you should meet doctor. So the doctor will assess you, will counsel you, I will bring you on track, so that the whole condition can be reversible. So please try to remember this pre-diabetic range can be reversible, and then depends upon you, like how frequently you go for walking or exercise, how much time you will spend with good healthy diet, then how much time this remission, this reversibility will depend on these factors. So the prevention, just we talked about it, weight loss, and then sedentary lifestyle should be avoided. So somebody having clerical job, they're sitting for a longer period of time at the office. Every 1 2 hours, they should get up around and walk around 5 minutes to avoid this continuous sitting, which can increase the chances of getting diabetes and even heart disease also. So exercise, good diet, and avoiding these sedentary habits, these things we can help in preventing diabetes, because family history that we cannot change it, but these things which are in our hands, which can help us in preventing diabetes. So this is very one important thing I would like to share with you. American Diabetic Association 2025, they have shared one risk score, like who are at risk of getting diabetes. So this is a 7-point questionnaire. If it is like age, family history, what is your weight, okay, whether you are physically active, how frequently you do the exercise. So these are some of the scores which are given here. So if your score is 5 or more, that means you are at risk of developing diabetes. So in such conditions, you can meet a doctor. You can screen yourself for whether you're having diabetes or not. Okay, this is very important. This is available in the internet. You can just type it American Diabetic Association diabetic risk score. You will get it so that you can assess your risk regarding the diabetes status. So once who is already diabetic, so what are the goals for sugar control? The fasting should be, these are all mentioned by American Diabetic Association. The fasting should be between 80 to 130. And then 2 hours after postprandial, it should be, that means after eating 2 hours after food. Usually, always do it in the break after breakfast. Okay, 2 hours after breakfast, not after lunch or dinner, because that is the time where you will find the highest sugars in a day. So 2 hours after breakfast, if it is between 120 to 180 is the target. So what about 3 months average sugar? That is the HbA1c. It should be between 6.5 to 7%. These are the 3 targets to be maintained so that the complications of diabetes can be prevented or postponed. So one important thing I would like to tell you about the monitoring of glucose levels. So somebody who are on insulin or somebody taking oral medication, oral tablets, there are two different kinds of means for monitoring glucose levels. One is the age-old one, this the very established one is the glucometer. So everybody will ask me regarding how far this glucometer is accurate when compared to the lab readings. So this is based on the scientific data, the previous studies that have been conducted, they compared the glucometer values with the lab values. Then they come to a conclusion that venous, that is the lab blood glucose levels, and the glucometer readings are almost the same during the fasting state. In the fasting state, both are almost the same. But after meals, there is a 10% variation between the lab value and the glucometer value. So usually they say lab values will be 10% lower than the glucometer value. But this is about the older scientific studies. The newer machines that are in the market right now. So majority of the glucometers, now they are having good algorithms. So good configuration so that they can reflect or almost maybe same as that of lab blood glucose levels. Otherwise, they say that if there is a 15%, 10 to 15% of variation between the lab and the glucometer, that is considered a standardized or configured glucometer. So this is about American Diabetic Association. They claim that when the sugars are very low or very high in the normal range, there should be around 10 to 15% of the variation. More than that is considered that glucometer is not properly configured. Then you can go to the manufacturer or you will find control solution to make sure that whether it is really well calibrated or not. So the one which we recently it is coming is the sensor, everybody will say, that is called continuous glucose monitoring system. So glucometer is there nowadays. So why this has come down? Because for monitoring glucometer, you need to prick every time. The drop of blood, it should be applied to the strip, then it will give you the reading. But this CGMS or continuous glucose monitoring system will have a sensor that you can see in the slide. This will be attached to forearm or the stomach or the back. Okay, so this how this sensor will work for 15 days. Okay, every 15 days it has to be changed. That means there will be a one prick for every 15 days. So how this one will work? Usually glucometer will collect blood from the will collect the capillary blood, that is from here. This is a red one, you can see the vessel. From here you will see the blood that is taken up for using glucometer. But in case of sensor, it uses this interstitial fluid that is outside the blood vessel and below the skin, the fat. There is some watery content that is called interstitial fluid. So it will continuously, there is a sensor here. It will be completely dipped into that interstitial fluid or that water outside the blood vessel. So it will continuously give the reading. Now we are having real-time sensors. They are flashing sensors where you will intermittently scan and then check the value. So now we are having real-time thing because this sensor will real-time, they will read the sugar levels inside this interstitial fluid every 5 minutes. Okay, so this is the recorder you can see in the diagram. You can see the person has worn it over the forearm. So it will transmit the data by Bluetooth, other NFC methods. So you can see over the recorder. But nowadays there are some many apps are there where there is no need for recorder. They can get all those values of sugar in the mobile itself. This is about continuous glucometer, continuous glucose monitoring system, or we can say sensor. So what is the advantage of this one? I told you the single prick for every 15 days. There will be a real-time monitoring. Every 5 minutes, the sugar levels, you can trace it. And then it will have alarms. So you can set alarm, like below 70 is considered very emergency, that is low sugar. So you can set an alarm at below 70. Maybe you can say set alarm at 70. So you will get an alarm saying that your blood sugar is going down. Then immediately you react by taking sugar with water or fruit juice, some other glucose jellies, anything, candy. So this is very good. Those who are continuously going into hypoglycemia, that is low sugar below 70, that is during sleep, while driving, it will be very difficult to manage or recognize. So in such conditions, this type of sensors will give you an alarm. So even you can set low sugar alarm even at 80 and 90. So if alarm comes at 80, there is a chance that sugar may go below 70. There will, even the sensor will have arrows. If down arrow mean sugar is going crashing very fast, then you will take a snack. Okay, this is how this sensor or continuous glucose monitoring system will help you in monitoring as well as in controlling the blood sugar levels. Okay, this is also very important. So every 15 days, the sensor has to be changed. So one prick in every 15 days. So one important thing I would like to tell about this sensor is a lag time, because this is measuring sugars from this water outside the blood cells, blood vessels, that is interstitial fluid, but not from the blood. So there will be a lag time of 5 minutes. Okay, that the sugar that is reflecting now may not be present sugar. It may be a 5 minutes back sugar levels. That's how it will differ from the glucometer. Regarding the accuracy, there is a 10% MARD, means mean absolute relative difference. So there are very good studies to say the sensor, glucometer and lab values. So there is around less than 10. Nowadays, all sensors, the newer sensors in the market has less than 10% variation. Okay, so that it can be very accurately, they can show you the readings only corresponding to the lab sugar values. So this is how the patterns will be once somebody who is wearing a continuous glucose monitoring system. First, there are three different kinds of graphs. One graph will give us the idea to the physician or the primary care doctor. So this green one, that is called time in range. So if you can see in the previous slide, you can see in this slide, the green one. So this is set from 70 to 180. This is considered normal range. So this green range in the graph, the upper part, it should be above 70%. So when we look at this application, then we'll see this green bar should be 70%. So in this example, it is only 46%. That means still many sugars which are high. Okay. So the high sugar should be less than 5%. Very low should be less than 2%. So here, if you can see, still the particular patient has not achieved the green one. So that means good sugar control. Still orange, the red one is more, even low sugars are low, more. Okay, if you can see here, the down one on the left side, in this green bars, the green area reflects the normal sugar control. Okay, the one you can see the red color patterns. So maybe after taking food, there is some peak of sugar levels, if you can see here in this graph. Similarly, somewhere in the early morning hours, there is a dip in the sugar level. You can see the red ones going down here in the morning level. So this will give us idea the morning sugars are going down, and then after food sugars are increasing. Then we can adjust the dose of insulin, or we can ask him to be or her to be careful because the sugars are going low. Try to reduce the morning dose of insulin or take a good amount of snack there. Okay. So this is how the sensor will help us in. So other thing, it will give us the idea about the last 7 days or the 14 days chart. Not only single day, it will give the last 7 days readings we can make out, and then last 14 days also we can make out, last 2 weeks. So the red you can see the red ones, that means they are going lower than 70. This is low hypoglycemia. Some peaks, probably postprandial peaks after eating food, it is going higher. Okay, based on this, you can adjust the dose of insulin or advise him regarding the diet, at what part of day the sugars are going high, when the sugars are going low. So the person can set up alarms saying that this is the time where sugars are going low, so then you can take one snack there. The sugars are raising, the arrow is showing upward arrow, then they can go for exercise. They can increase the dose of insulin during that part of time with the help of the doctor. So very important topic that I would like to mention in this newer diabetic management is the fatty liver. Everybody might have known about this fatty liver. So this is called non-alcoholic fatty liver. This somebody taking alcohol getting fatty liver, that is a different thing. This is a non-alcoholic. So why this is very important? Because this is very common nowadays because of overweight, obesity, diabetes, these things. So why should we diagnose it early, and why should we manage it? Uh, Otherwise, what will happen? So if it is not managed and diagnosed at appropriate time, then what will happen? Liver cirrhosis can come because of the deposition of fat in the liver. It can lead to reduced function of the liver. It will become smaller in size. That is called liver cirrhosis. It will not function properly. At the end, it can lead to liver cancer. So this non-alcoholic fatty liver is one of the major reasons for increase in the liver cancers nowadays. Okay, this is going to happen if it is not treated properly. And then second one, the most common cause of death in those having fatty liver disease is the heart disease. That means those who are having fatty liver, there is increased chance of heart disease. So that's why how to recognize this fatty liver? There are five points. Somebody having overweight or obesity, there is at risk of getting fatty liver. Having pre-diabetes or diabetes, they can get fatty liver. Those who are having high blood pressure, higher triglyceride levels, that is in one of the lipid profile, this is the triglyceride level more than 150. Okay, and then if the HDL, that is the good cholesterol, if it is low, or somebody taking medicine for cholesterol, these are some of the things where we can say if 5 points are there, if at least 1 point is there out of 5, we can say they are maybe prone to get fatty liver. Then how to assess? Once you come to the hospital, we use a calculator that is called FIB-4. So this was in ADA 2025 nowadays. American Diabetic Association 2025 formulated. This is the FIB-4 score, where age, liver enzymes, and platelet count. We enter the value. It will give a score. Less than 1.3 is considered normal. 1.3, 2.67 is borderline. More than 2.67 is very high risk for fatty liver. This is an online calculator. Anybody can get it. So this is what we use in our clinics to know whether he needs attention for fatty liver or not. So once we see FIB score of more than 1.3, then that means he's having a significant fatty liver. Then we'll advise them. So I will tell you in the next slide how to manage it. If it is more than 2.7, we need to refer to gastroenterologist, the specialist for the liver and all. Why should we refer to him? Because they will do separate scan called fibroscan. Because in the early part, the fibroscan shows they will measure liver stiffness. How is the elasticity, stiffness of the liver? So if it is more than 8 pascals, kilopascals, that means the stiffness is very much. So they are prone to get chronic liver disease, that is liver cirrhosis or liver dysfunction. In such cases, the gastroenterologist will manage accordingly based on this. So we'll refer them at this point of time to the gastroenterologist for further management, for doing fibroscan to assess how is the liver stiffness and all. Okay, then how to manage this fatty liver? So in majority of the people, it is reversible, like prediabetes, which is reversible. So how can we make it reversible? By diet. So what type of diet? It should be very low. You should be taking very low amount of refined carbohydrates. The polished rice, like refined flour, usually white kubus, white bread, these things should be avoided. And then don't take processed food because there are calorie dense foods, usually the packaged one. So there is a chance of increase in cholesterol, weight gain, those things can happen. And then increase the fiber content in food. What is the fiber content? You should increase usually salad, the vegetables, and then fruits. Usually they are enrich in fiber. Instead of fruit juices, fruits are better. Whole fruit is always better. Then exercise, maybe 30 minutes brisk walk in a day, covering around 2.5 kilometers, at least 5 days in a week. And then weight loss. If you stick to this diet and exercise pattern, then you will have good amount of weight loss. Then fatty liver will come down. Okay. So if they, along with this diet, exercise, and weight loss, there are certain medications like pioglitazone, semaglutide. These are the two medications that are approved in 2025, American Diabetic Association. So why they have been approved? Because these two medications, they can change the histology. That means liver structure. Somebody having fatty deposition, going into the liver problem. So these two medications can reverse those liver cell changes. So that's why this is very important to meet a doctor and to assess whether you really need those two medications, so that we can avoid future liver cancer risk or liver problems like liver cirrhosis risk. And then you can avoid even heart disease problems if you can treat fatty liver, because the same things, diet, exercise, and weight loss, even reduce the heart disease risk. So one thing is, it's a multidisciplinary management. Endocrinologist, once you come to us first, we'll evaluate you, and then we'll take the help of gastroenterologist, will refer you when it is appropriate, and then dietitian will assess you and will give you the standardized meal plan and then exercise patterns. Okay, regarding the how to manage this diabetes, everybody know about the diet, exercise, and weight reduction. This is the main thing for type 2 diabetes. So type 1 is different. Even they do need diet and exercise. They require insulin as per the carbohydrate count and all. So in this diet, this is called plate method. So in this plate method, we always tell the patient, whenever you are having food, make sure that your plate, half of it should be salad. Usually what type of salad? It should be non-starchy vegetable, not like potato, tapioca, other starchy vegetables. Should be non-starch. It can be carrots, broccoli, or it can be cucumber, some leaves. These are called non-starchy vegetables. Cauliflower, cabbage, these are all non-starch vegetables. So it should be around half of the plate. And then rest of the half, you can make it into two equal portions. 1/4 should be grains, maybe rice. Try to avoid white rice. You can take brown rice, unpolished rice, then or semi-polished rice. Second thing, the bread, it should not be white bread or not even the brown. It is called whole wheat or multigrain bread, because there's a difference between brown bread and wheat bread. So if there's a baking method can make the bread brown, but it doesn't mean it doesn't contain refined flour. Okay, so you should always look for a multigrain flour you should be using, or whole wheat flour can be used. So whole wheat multigrain bread should be taken. So this is how you should be taking complex carbohydrate. And then rest of the 1/4, you can take proteins, maybe in the form of beans, lentils, egg, fish, chicken, and then meat. But you should not be frying them. It should be boiled or steamed. Then try to take skinless chicken. So these things are very important in reducing the calorie. Try to eat lean beef. Okay, lean beef will have less amount of fat and then less calories compared to the whole beef. Similarly, regarding the juice, smoothie, and fruit. So everybody will ask me, why can't we take smoothie? This I'm talking about diabetic persons, those who are obese. Because if you take juice, for example, apple juice versus apple. So somebody taking 150 ml, 200 ml of a juice. So that definitely require 3-4 apples. Okay. So large amount of apples is they are used for preparing juice. At the same time, the fiber content of the apple will not be there in the juice. So more calories without any fiber, easily digestible. It can increase the sugar and weight. So always better to go for an apple rather than juice. Then what about smoothie? Smoothie, they say smoothie is not, will contain fiber also, because they were not wasting the fruit. It will have the apple, whole thing will be there. But only thing is the blender will blends it, right? It grinds it. When you eat a fruit, you will chew it. Then saliva is produced. Then brain will send a signal for early satiety. That means the food, whatever that you are eating, will stop because of the satiety, early satiety. So then it will cause weight loss. If you grind it by using blender, it will be very fine. The fiber will be broken completely. So that what will happen, it will more look like a semi-solid or a liquid form. Then it will be easily digestible. And the fiber which is not digestible going into the colon or the large intestine, relieving constipation, those effects will not be there with the smoothie. At the same time, because of the very fine fibers, broken one, they are easily digestible, and then it will not help you in losing much weight. At the same time, smoothies are very calorie dense. They will have very high calories. You will blend 2, 3 kinds of fruits, everything, and then the quantity. So always the smoothie will have a high calorie, the fiber which is not compatible, so which is not good fiber, and then it will not give you good results. So always when compared to juice, smoothie may be better. When compared to smoothie, a whole fruit is always better. Always take fruit instead of smoothie or so your stomach will be full with an apple compared to apple juice. Okay, regarding the exercise, this is American Diabetic Association 2025. They have put up this chart. It controls, it says we should at least walk. What type of walking? It is a brisk walking. Brisk walking means it should be, you should walk for 30 minutes, at least 5 days in a week. And how much is the speed? You should cover around 2.5 kilometers in 30 minutes. Somebody says, doctor, I'm walking 1 hour every week, every day, but I'm not able to lose weight because not able to maintain the speed. In 1 hour, somebody is covering only 2 kilometers. Then it is not a good speed. So it is not considered a brisk walk. So 30 minutes, somebody covering 2.5 kilometers is considered a brisk walk. So that much should, the speed should be maintained. And then main thing is the sedentary habit. Nowadays, we are having type 5 diabetes. So what is this type 5 diabetes? Even in now, International Diabetic Federation, IDF 2025, they have put forth new form of diabetes that is called type 5 diabetes. So type 5 diabetes means previous generations, maybe those they are in the rural background, they are in the villages, maybe their birth weight may be very low, maybe 2.5 kilo, 2.6 or 2 kg like this. And then suddenly those generation people are coming to the urban areas, they are exposed to the nutritious food. So low birth weight, exposing to the nutritious food, and then suddenly becoming sedentary lifestyle, clerical job, sitting in the offices. So that type of conversion from the rural background, low birth weight, suddenly exposing to the nutritious environment, and then sedentary lifestyle, causing the diabetes, which is called type 5 diabetes. So that is sudden exposure to the high calorie food. So this type of diabetes, like in those, pancreas size will be small, but if they are exposed to very good quality, high nutritious food, and then not doing any exercise, sedentary lifestyle, gaining weight, so pancreatic size is not sufficient to produce enough insulin. So this behaves like a type 1 diabetes. So this is not like type 1, but this is called type 5. So this is the new variety I would like to stress you about. There is type 3 also. This is the type 5 which is newly added. They defined it in 2025. So you can discuss with your doctor regarding this. So this is how from rural to urban migration, exposing to nutritious food, gaining weight, sedentary habits causes this type of diabetes. This is called malnutrition related diabetes. So the stepping, you can count, they say around 7,000 step is enough, 10,000 step per day. There are certain studies to say they reduce the heart disease risk. Even the sleep is very important, 6 to 8 hours of good quality of sleep. The sleep is very less, it increases the insulin resistance, increases the cortisol levels, it increases the fasting sugar levels. Okay, the sleep pattern is very important. Another thing is the strengthening. So we tell our diabetic persons to do some strengthening exercise along with walking, because good strengthening exercise will improve the muscle strength. It will reduce the fall. If there is a reduction of the fall, then reduced fracture of the bones. That is one in somebody who is having age more than 50 years. So this strengthening is very important. At the same time, this strengthening not only strengthen your bone, it will also reduce the sugar levels. So this is regarding American Diabetic in 2025. So this is one whole method I always show it to the patient. So these are the methods which we should be following: the good sleep, strengthening of muscle strengthening exercises, brisk walk, and then stepping. So I will say at least first floor don't use the lift. And then when you are sitting at office for a longer period of time, 8 hours in a day or around 7 to 8 hours, if you are sitting, then every 1 2 hours you should get up and walk around for 5 minutes. This itself will reduce the risk of heart disease, and then the sugar level will not spike. So regarding the medication, so what is the new about these medications? So previously the medications what we used to prescribe is based on sugar levels alone. Okay, if the sugar is like 150, 200, 350, 400, you do like this, you start insulin, you start this tablet like this. But nowadays, the management has completely changed. It says that not only the sugar levels, you keep in mind other associated factors with along with diabetes. What is that? One is the weight. Somebody who is overweight, obesity, we are having certain medications like empagliflozin, liraglutide, which can reduce the weight along with controls the sugar. If somebody having heart disease risk, so now we are having certain medications which not only controls the sugar, it will improve your heart condition. Okay, it will reduce the future heart related risk. So that's why we use certain kind of medications. Empagliflozin is there, liraglutide is there. So those things are very good. If we use them, diabetes with heart disease, we use them. Or somebody having diabetes with heart disease, the kidney risk, kidney problem is there. Then we use certain medicines. So which can reduce the protein loss in the urine, which will control the sugar, it will protect your kidney. Okay, these are the SGLT2 inhibitors, mainly the empagliflozin. You might have heard of those medications. So nowadays the management is completely changed. So we take into account not only the diabetes, the weight factor, heart disease risk, any kidney problem is there, and very important thing is the heart failure. Somebody having heart failure, they will have difficulty in breathing, heart is not pumping normally, they are having high sugar. Now we are having medicines like empagliflozin, which can reduce the hospital admissions for future heart failure. So these medicines are very helpful in these patients. Some medicines which can prevent the stroke, brain stroke, along with sugar management. So this is the change in the management of diabetes. So here we take into account all the factors, not just the diabetes. So this is the wholesome, holistic management of diabetes, preventing other risk factors, or those who are already having a heart disease, already having a kidney disease, already having a brain stroke or a heart failure. So those certain medications controlling the sugar can also reduce the risk of future hospital admissions, future heart disease risk, or increase in the intensity of the disease. So this I would like to mention about this latest medications. So now we are having, now we talked about oral medication, the tablet forms. Then what about the injectables? So age old one, insulin. So when do we prescribe insulin to the people with diabetes? So type 1, they will be on insulin for a long-term period. Regarding type 2 diabetes, initially they will be on tablets. Later on, they may need insulin. So who will need insulin? Somebody say like 10 years, 15 years of diabetes on medications, 2 to 3 different kinds of tablets. Still fasting sugar is more than 200. So already the patient is taking 3 varieties of oral tablets, tablet forms, and then doing very good amount of diet, exercise, 15 years of diabetes, still they're not able to control the fasting sugar is 200. The fasting sugar is not related to food, right? We cannot ask him to control more food or lose weight because this is the fasting. Our HbA1c 3 months is more than 10%. So then this is the time where pancreatic beta cells, they are not functioning properly because it has been 15 years of diabetes. Gradually the function is coming down, insulin secretion may be going down, then they may need insulin. So for a short term, we use those who are having wounds that requires any debridement surgery. Before surgery, when they are admitted in the hospital, for a brief period of time, we change from oral medication to the insulin form. Then immediately after a week or 15 days, they can be converted back to insulin, the oral tablets. So one myth I would like to tell you, because many of the patients will come and ask, insulin is harmful. So insulin is never harmful, because insulin, whatever that is produced in our body, somebody who is a normal person who is having normal sugar, that is because of the insulin levels in the body. When you eat, insulin level will be released in the body, and then sugars will come down. The same insulin, by recombinant DNA technology, this is the human insulin now we are having at this point of time. Before there were animal insulins, now we no longer use animal insulins, all the human insulin with recombinant DNA technology. So insulin is not harmful at all. Definitely it will control the sugars. It is same like that of insulin is present in your body. And then second myth is, on insulin means my diabetic life has reached the end. That is not true, because even though somebody having 10 to 15 years of diabetes, if you take insulin for 1 month, 2 months, then there will be some rest to the pancreas. Then after 2 months, there is a chance that it will produce insulin in a better manner and then control the sugar levels with very few medications. So in young onset diabetes, like diabetes in very young people, less than 40 years of age, which I'm very much interested, even in children from 10 to 40 years. So when somebody, young person, comes with a first time having diabetes with HbA1c of 10%, sugar is of 350, 400, if you give them insulin in the first visit, a month or a month and a half, then certain people, around 10 to 20%, there is a reversibility. But not about type 1, I'm talking about type 2 or other types of diabetes. So that is how insulin is very important in young people, very high sugars at the first visit. If you give them insulin, pancreas will be at rest. So that if you don't give insulin, give the tablets, there will be more tension created over the pancreas. It will be squeezed more to get insulin. So that's why if you give insulin the first 1 to 2 months, then many people can go into remission after insulin, and then they may need very less amount of tablets at the end of insulin. So this is a good thing about insulin. And then it is permanent. Other myth is permanent. It is not like this permanent unless somebody having many years of diabetes, beta cells of the pancreas not completely working. For them, it may be permanent, but majority of the people, it is not permanent. Like somebody getting admitted in the hospital in 15 days, will shift them back to tablets. Okay. And then other injectables, the newer ones which has come into the market, which are approved by FDA. These are all liraglutide, semaglutide, tirzepatide. You might have heard about all these things nowadays. People are using it for losing weight. Okay. So this is how the management has been changed in the diabetes nowadays. Okay. So not only diabetic, those who are obesity without diabetes, these medications can cause weight loss. But what is the criteria that we use to prescribe the medication is the BMI, body mass index, more than 27 with diabetes, having poor sugar control, they are eligible to take this medicine. Or those who are not having diabetes, but BMI is more than 30, okay, still they are eligible to take. But always you should meet the healthcare professional, because we are having a 3 structured pattern prescribing this drug. Initially, we assess you, okay, whether you are eligible to take it or not. We'll take many history things. We'll do the further some evaluation. We'll examine you and see whether you are eligible to take these kinds of medicine or not. Then once you initially we'll evaluate it, then we'll look at the eligibility, and then we'll prescribe the medicine. Then we'll explain to the patient the pros and cons of the medication. Okay, because let us take example of semaglutide and tirzepatide, which can cause profoundly weight loss. Semaglutide can cause around 15% to 20% of weight loss. They'll say this is 20 to 30% of tirzepatide can cause weight loss. Okay, so before prescribing, we always take into consideration whether they are really eligible to take based on weight and sugar levels or based on weight alone. Along with that, we check regarding the thyroid status, because there is a black box warning with this tirzepatide and semaglutide and liraglutide is that in animal studies, they have found out that it can cause thyroid tumors. So we always take history. If there is a family history of thyroid tumors, if there is a personal history of thyroid tumors, before they underwent thyroid surgeries for the tumors, so we don't prescribe them these type of drugs. So though it is shown in the animal studies, there is a black box warning from the FDA. Similarly, we counsel them saying that these medications will reduce your appetite. There will be delay of food from the stomach going into the intestine. So you may feel some distension, some sort of vomiting or diarrhea-like sensation. So very recently they have found out, so these drugs may, in 1 in 100,000, there is a chance of involving the eye nerve, causing some blindness, reduction of the thing. So we always counsel the patient, we'll tell them what are the pros and cons of these medicines, and then where benefit outweighs the risk. Somebody with obesity having obstructive sleep apnea, that means they're having snoring, not able to sleep properly, there is no oxygenation during sleep, so they are eligible, they're very good at problem, so they need to reduce the weight. Those who are having heart issues, knee joint arthritis, knee joint problems, okay, so much weight is there, sugar is not getting controlled, many medicines are taking, insulin they are taking. So in those conditions where benefit outweighs the risk, then we'll counsel them, then we'll prescribe the medicine. Once we prescribe, the third one is the follow-up. So on follow-up, we'll see how the patient is doing with the medication. So what about the side effects they received, whether they can be managed, or we need to reduce the dose, or the dose can be escalated very safely. So these three patterns: initiation, looking for the eligibility, and follow-up. So this should be taken with the guidance of physician. Okay, otherwise, so always discuss with your doctor regarding this prescription of these medications, regarding the eligibility and initiation and follow-up. Okay, so this is about management. So if you are having any queries regarding the management of the diabetes, please you can.
Yeah, Dr. Kishore, wonderful presentation.
Yes.
For last 5 years, we are doing it one-on-one. Good experts are giving the talks. Your way was completely different, very interesting. Not a single minute I was out of the screen. So I was listening to you very carefully. And
Thank
you have given wonderful things which we always remember. So definitely there are many questions, but I'll start with the questions, the chat box. Uh, Satraj is asking about his father. His father's HbA1c is 5.9 and his cholesterol levels are high, for which he is taking Lipitor 20 milligram. And on routine tests, his fasting sugar and after food are well within the normal limits. But HbA1c fluctuates between 5.8 to 6.
Okay.
Do he need to start medicine for diabetes?
Okay, so right now, at present, now his HbA1c is somewhere between below 6.4. He's only pre-diabetic right now. So below 5.7 is considered normal. 5.7, 6.4 is pre-diabetic. So if he's very good with his diet and exercise, there is no need to start medication. Suppose if they say it is not possible to control these sugars by using diet and exercise, then we may start medicine. But if the fasting postprandial sugars are normal, HbA1c is in the only borderline range, there is no need. You can control it by doing diet and exercise.
Yeah, true. Or if there is any other complicated thing or comorbid conditions, they
So we
may.
should screen. Yes, even pre-diabetic conditions, we need to screen for retinopathy, and then heart disease risk. That is also very, very important, not just in
True.
diabetic persons.
Uttam Tawang is asking, I read somewhere that chronic medication for blood pressure can increase the risk of diabetes. Is it true? This is a very interesting questions we come across many times during the events. People used to say, why you are diabetic or you are having high blood pressure, why you are not taking medicine. So they have different excuses. They
Yes.
read from all social media. So
Okay.
what's your thoughts on?
So I would like to clarify regarding this point. So as I showed you in the slides, high blood pressure is an independent risk factor for diabetes. Somebody who are having high blood pressure, their chance of getting diabetes compared to others is high. Okay. Regarding medications which can reduce the blood pressure, we don't have any studies to say that these things will increase the sugar levels. But yes, there is one medication I would like to tell you, that is the for using the cholesterol medicine. Somebody using medicine for cholesterol, like statins, will say rosuvastatin, atorvastatin, they can increase diabetes. Okay, but in such conditions, if you say somebody who is already having a heart disease, okay, somebody who is at risk of getting a heart disease, but if you start statins, this atorvastatin and rosuvastatin, then you can reduce the risk of heart disease. That is more important than having diabetes. Okay, so that's why. So those medicines can increase the risk of diabetes to some extent, but not these medicines for high blood pressure.
True.
So
Next question is from Harshad. You mentioned about the fatty liver, which was interesting correlation
yes,
for all the patients with or without diabetes. So,
yes.
will a person with fatty liver develop diabetes?
Yes. So somebody with fatty liver can get diabetes. Somebody with diabetes can get fatty liver. So it's something like inflammation. So we'll say inflammation in the body can lead to many things. A heart disease, it can become a person diabetic, make a person diabetic. It can lead to so many other problems. So this fatty liver can lead to inflammation kind of thing, where so many interleukins will be released, causing this type of insulin resistance and diabetes. Definitely. So this fatty liver can also increase the cardiac disease, heart disease. So one of the leading cause of death in those with fatty liver is the heart disease risk. So that's why it should be screened and then managed it at very appropriate, very early.
Yeah. Next question is from Nida. Is there any natural way to improve the insulin sensitivity?
Yes. So when somebody is having insulin resistance, let us say insulin resistance means So they are producing insulin, but there is an obstruction that is called insulin resistance. So how to improve that insulin sensitivity, you will say, not like increasing the insulin production from the pancreas. It is called increasing insulin sensitivity. Whatever the insulin in the body should function properly. So the main thing is how to reduce this insulin resistance by improving the diet. Take more fiber, less amount of refined carbohydrates, and then very oily, high calorie dense foods. Then your weight will come down. So this fiber rich diet will improve the insulin sensitivity. Second thing, exercise. So I described you in that slide about 30 minutes brisk walk as recommended by American Diabetic Association. So definitely it will improve the insulin resistance and sensitivity. Insulin will work very nice. And then ultimately the weight reduction. The diet and exercise will lead to weight reduction and improvement in insulin resistance and improving insulin sensitivity. So if this is not possible or still not able to achieve this thing, then we are having a drug medicine called metformin. So metformin will reduce the insulin resistance. Somebody who are having pre-diabetic, those who are having early diabetic, the HbA1c is only 6.6 or 7 or in the pre-diabetic. So metformin can reduce the insulin resistance. That can improve the insulin sensitivity. But ideal compared to metformin, diet and exercise is definitely better than metformin. Thank you.
True, true. The same connected question. Bharat has asked, do insulin resistance in diabetic patients result in obesity? Because many people start losing weight in diabetes.
Okay. So that weight loss due to diabetes is not that every diabetic person will lose weight. That depends on how high is the sugar. The sugar is very high, like 400, 600, or if there is a sudden increase in sugar, then they will start losing the weight. Somebody having slow rise in sugar, like type 2 diabetes, where they will be initially will be 100, become 120, then 140, then 250, they will not lose weight. If there is a sudden rise in sugar, then there is a chance that they will lose weight. But one thing I would like to tell you, weight gain lead to insulin resistance. Insulin resistance causing weight gain, that is not completely true. Some people will ask me, like polycystic ovarian syndrome, like women. So, sir, sorry, I'm having PCOS, so there is a weight gain. It is not correct. Because of the weight gain, somebody developed PCOS. This is a lifestyle condition. So if you lose the weight, definitely insulin resistance will improve, PCOS will improve, other things will improve.
Yeah. That was interesting. Similar to like we say, all in social media we used to read. Mr. Singh has asked, recent research and study shows diabetes can be reversed. Even you were talking about reversal. So what exactly is meant by reversing diabetes? Does it mean there is no requirement for care management?
Yes. So that is a very nice question because there is a direct study. This was conducted some 10 years back. I think it was conducted in the England, UK. So multicentric study. So remember that this is in type 2 diabetes. Everybody will get confused. Reversibility means any type of diabetes reversible. So type 1 diabetes, it cannot be reversed. They will be on insulin. So this is about type 2 diabetes. Type 2 diabetes, those who are having insulin resistance, those kind of things. In this, they have mentioned that somebody who is losing 15 kg, there is a chance of 30 to 40% chance of remission. So remission means the sugar levels will be under control. They may not require any medication, definitely, or very less amount of medication. So remission means not requiring any medication, definitely not requiring any medication at the end of 2 years. But how long this remission will last? As long as you are controlling your diet, exercise, managing your weight properly, then it will be under remission. So now you say my diabetes is gone. I have lost 15 kg. Then you stop controlling diet, exercise. You will start gaining weight. Again, the sugar levels will rise. So this is not called cure. This is called remission. So direct study clearly says there is a 40% remission if you can lose 15 kilos. So in the clinic, I will say every patient, even type 2 diabetes nowadays, it is reversible. Please lose this 15 kg. You can do wonders. You can stop the medication. So remission, how long it will stay, it is depend on you. How long you will keep your lifestyle healthy.
True. Until unless you sustain your effort, it will not
Yes.
come back.
The same thing
Yeah, that's
happens with
good.
like nowadays where we are starting injections, somebody undergoing bariatric surgery, they will lose so much weight. Then at the end of 5 years, 6 years, even after bariatric surgery, now people are coming say, doctor, I'm gaining weight. That is
Meaning,
because
right.
the changes can be reversible.
You have to religiously follow the
Yes.
protocols. Okay, next question is from Poco. I am obese. My blood glucose levels are very high. I was put on insulin for 6 weeks. along with oral medication. Now I am on oral medicine only as my fasting and post glucose levels are within acceptable range. But my HbA1c is mostly above 7.5. Now I have been advised for Munjaro. I read there it has side effects. I'm confused. She's confused. Suggest this.
Okay. So regarding HbA1c and sugar, I would like to tell you, if there is a discordance between sugar levels and HbA1c. The sugar levels are normal, HbA1c is high. That means because we are checking sugar levels in the morning, fasting and after breakfast, there may be higher after lunch, after dinner, we don't know. That may be the average of all the sugar levels is considered HbA1c. So that is one. So that's why HbA1c, if the discordant means we should check with your glucometer as a sensor. What about other times of the day? After lunch, dinner, maybe somewhere it may be high. That is regarding discordance between HbA1c and sugar. And second thing, regarding other pitfalls of HbA1c, I'm not looking into certain changes like sickle cell anemia will alter HbA1c. Then regarding Monjaro, uh, to know about Monjaro, I told you we follow 3 steps. That is the NHS protocol. So whenever a patient comes, we'll tell them, we'll ask them, what is your goal? How much you want to lose? It is 10 kg, 15 kg, 20 kg. That is how long you want to use. Then we'll counsel them regarding the mechanism of action. So this will affect your appetite center. It will reduce the appetite. It can cause food will stay in the stomach for longer time. You will feel like bloating. Okay. And then you will have distension, vomiting, diarrhea. These are some of the minor side effects which can be manageable. So we always in detail, we examine their thyroid gland. We'll ask the history. Is there any family history having thyroid tumors? That's very important because now FDA has given a black box warning. So those who are having a family history or a personal history of thyroid tumors or neck surgeries for these tumors, better not to use. It didn't say contraindication or something. It is there in the animal studies, but we always take a full history. We evaluate them. We'll see whether the person is very eligible or not. Okay, so please meet the doctor. Then every doctor is very happy to counsel you regarding the pros and cons of medication. Okay, so don't jump. Always start with a smaller dose like 2.5 milligram regarding Monjaro. Then every month you escalate it. Then the side effects may be less. Some people they want to lose it very fast. They want to start at a very larger dose. They will end up in complications. Okay, thank you.
Yeah, true. And nowadays, Manjaro is available OTC also. So don't try to use it without the prescription of or evaluation by a physician. So you should be following the protocol. Now, next question is from Dr. Poonam. It's a very interesting question because she has merged many things. What is the key daily habits, practical habits to adjust nutrition, mainly for the diet, mainly in diet for the people who have PCOS and have insulin resistance? And other thing to reduce the insulin resistance without relying on metformin, like you said, first medicine is metformin to reduce resistance. So, what is your call in this talk?
So similarly, whenever such patients come to me, I will tell them type 2 diabetes, PCOS are the same. They belong to the same spectrum because same genetic background can be there. So somebody in the family having diabetes the siblings can have PCOS because the same gene which can cause diabetes can cause polycystic ovarian syndrome. So the genetic history that we cannot change it, but other things which are in our hand, that is called modifiable factors. That is the diet, exercise, weight reduction, these are in our hands. So as I told you before, like weight gain is causing PCOS. It is not the other way around. Some people will think PCOS itself is causing weight gain. No, not like that. This may be a very less extent. Majority of the time, weight gain is causing PCOS. So high other hormones may cause some things, but it is not complete. Okay. So always I would like to tell you, we can reduce insulin resistance and then PCOS. PCOS, other thing is the lifestyle related PCOS. I'm not talking about other hormones which can cause PCOS, like hypothyroidism, problem in the prolactin, problem in the cortisol can cause PCOS. Those things will not respond to diet. Okay, we need some other hormonal medication to reduce that type of PCOS. We are talking about primary PCOS, lifestyle related PCOS, which can respond to diet, exercise, and weight reduction. So these things, diet, as I told you, less amount of refined carbohydrates. Take more complex carbohydrates. That means brown rice, whole wheat, multigrain, some millets, and then avoid packaged foods, the processed foods. They are very, very, very calorie dense. Then easily digestible like chips, the bakery items, those things can cause more weight gain. And then I can take more fiber. Fiber is the thing which is very important. I showed you the plate method, Mediterranean plate method. Half of your plate should be fiber. It should be usually vegetables. So which are non-starchy vegetables, not the potato. So these things, if you follow that, the brisk walk, whether it may be cycling or going to the gym, very important thing is the consistency. I will always tell the patient, you start the diet and exercise today. Then after a week, a month, you will say, oh, doctor, I'm not able to lose. Then you will stop it. So you should be doing it with consistency. Definitely will give you good results. It can reduce your insulin resistance, periods can become regular, and the PCOS phenotype will become better.
Yeah, true. Dr. Poonam has again asked a very interesting question because now people have started looking themselves in a cosmetic way also. So, what is your call for acanthosis nigricans? Because many people start developing this, and how to manage it, cosmetics concern with hormonal imbalance.
Okay, acanthosis nigricans. So if you look at any patient with diabetes or those who are at risk of diabetes, we look at some skin markers. Some markers over the skin. One is the acanthosis over the nape of the neck, armpits, over the temple areas, then around the lips. Many areas you will get the pigmentation. Skin will become thick and it will become pigmented. That means it will become little black colored and all. So this is called acanthosis. Along with that, if you can make out, there is called skin tags. If you can see over the neck, you will see some skin outgrowths will be there, very small. They are also like acanthosis nigricans, skin tags. These two are representative of insulin resistance. So if somebody, a child or an adult, if they're having acanthosis, skin tags, they are present means they are having insulin resistance, they are prone to develop diabetes, or we can say they are having type 2 diabetes, somebody having diabetes. This is how we can differentiate between type 1 and type 2. So acanthosis nigricans can be managed by reducing the insulin resistance. As I told you, the management is the same: diet, exercise, and weight reduction or metformin. But meanwhile, maybe dermatologist will give you certain creams or ointments in between. So you can follow up with the dermatologist also. Meanwhile, the permanent thing is to manage by diet, exercise, and weight reduction. By reducing the insulin resistance, acanthosis may come down with weight loss.
Yeah. Doc, I think we are running out of time, but I will take one question, one last question. What is your advice for a diabetic patient in emergency? What emergency situation can a diabetic patient develop?
So diabetic person, that depends on type 2 or type 1. So type 2 patients can land up in emergency. I will talk about low sugar first, hypoglycemia. So when sugar is below 70, that is also emergency. So immediately they will have shaking, sweating, everything symptoms will be there. They can take sugar with water or anything. So that is one complication. They can come to emergency. Somebody having no symptoms can straight away become unconscious. That is also very, so you should meet your doctor how to make it become aware of these low sugar symptoms. We'll have high targets, adjusting the dose of medication. That is very important. And second thing is the hyperosmolar hypoglycemic non-ketotic thing. So this is one condition where sugar level will be like 600, 700. There will be dehydration, sodium will go high. Then it will change the mentation. That is the consciousness of the patient. Patient will be confused. So they will have vomiting. So they will come to emergency. When we check them, sugar will be high, and then the urine ketones will not be there. Even the blood ketones will not be there. Even acids will be normal. That is the condition. Patient looks very much confused. So then if you give them fluids immediately, if you give them 1 liter, 2 liters, then immediately starts draining the consciousness. That is main about dehydration causing, high sugar is causing dehydration. Then we'll start insulin infusion. That's how we'll manage them. Another thing is the type 1 diabetes coming to emergency. They will have high sugars, they will have ketones, and then acids will be abnormal. So patient will be usually very conscious, very much conscious. That is the difference between the previous one and this one. So unless there is some associated infection, the patient with diabetic ketosis will be conscious. So we'll manage them. Main thing is the fluids. We'll give IV fluids. That is the primary thing. Then insulin, then other management will be there. These are the main things. They will come to emergency because of diabetes.
Thank you very much, Dr. Kishore. It was wonderful presentation, and your inputs for insights of diabetic care nuances was wonderful and appreciable. I think everyone got understood within simple languages. And next session, next Friday, we'll be having another topic. Our dietitian, Ms. Ruba, will be taking care of role of dietary approach for diabetes management. So see you then. Thank you, everyone.
Thank you.